And actually, then I was chief resident, so I had an extra year. I sort of came to pulmonary by eliminating everything else. But I think people in this audience probably really love internal medicine. That is why we do pulmonary medicine. And ultimately, I think that was the right choice for me. And it turned out the acid base was really pulmonary. That nephrology turned out to be like polycystic kidney disease and dialysis. And so that was like not good. So that's how I landed here. So, I'm glad to share that with kind of mission with all of you. I think we share that. So in 2003, when I was the director of that, and by the way, pulmonary oncology is directed by Jennifer Posick. So I should update that on my CV. Jennifer, are you here? Okay, yeah. Who's doing it brilliantly. In 2003, the Yale Cancer Center Thoracic Oncology Program was me, my nurse coordinator, and a social worker. And so you have to dream. Be careful because you might get what you want. But that was kind of the beginning of a non-linear journey in thoracic oncology. So thanks, I'm glad to be here. So let's get started. I have no disclosures and you should get your CME credit with that. So I'm going to give you a really quick lung cancer overview and really focus on the importance of early detection. I hope you're aware that there are lots of tools for lung cancer risk assessment, and we'll talk about some of the challenges of lung cancer screening. And leaving this, I hope you'll understand the health impact that lung cancer screening potentially has. I want you to implement the USPSTF current recommendations for screening. But I think as we look ahead to where screening is going to be in 5, 10, and 20 years, we have to consider the changing demographics of our population. So I don't know if this is going to work, but we're going to try to do poll everywhere. So the first question to you is, which of the following individuals do you want to refer for lung cancer screening? These will be listed on the next slide, so you don't have to memorize them. 50-year-old white male, 20-pack year smoking history, stopped 15 years ago. He's a college grad, BMI 27. He has no COPD, personal cancer, or family history of lung cancer. Patient B is an 81-year-old woman with a 60-pack year smoking history, current smoker, high school graduate, BMI 27, history of COPD, no personal history of cancer, and her father died of lung cancer. Patient C is a 74-year-old Black male with a 30-pack year smoking history, quit 20 years ago. He's a college grad, BMI 24. He has a history of COPD, but no personal history of cancer, and his mother died of lung cancer. And patient D is a 70-year-old Asian woman, never smoker, completed 2 years of college, BMI 25, has a chronic productive morning cough. She was treated for breast cancer 10 years ago, and her father died of lung cancer. So choose one answer, patient A and B, patient A, B, and C, or all of the above. Oh my God, it's working. Look at that. Okay, so the majority of people in here want to screen everybody. And some people have chosen fewer than that, but the majority of people want to screen everybody. Okay, we'll just keep that in mind. Question 2, which of those individuals, so same people, is eligible for screening based on the current USPSTF eligibility criteria? Just leave that up for a bit. Okay, and so most of you are saying patient A, and some of you are saying other patients because you're recognizing risk. So we'll come back to that. And let's just talk about lung cancer at a high level. So last year, about 125,000 Americans died of lung cancer, 65,000 men, 59,000 women. And these are the American Cancer Society data that show in the red line mortality from lung cancer in men and mortality in women since 1930, when these kinds of statistics were being kept. And you can see that still lung cancer causes more death in men and in women than any other tumor. And in women, that's actually been the case since about 1986, although that fact is not widely, I think, recognized. But you can see that the number of deaths has been coming down pretty steeply in men and also in women, though not so steeply. But I want to point out that of the estimated new cases last year, which were 234,000, more women were actually diagnosed with lung cancer in men. So this demographic of lung cancer is in the process of shifting, because it used to be that most lung cancer cases were in men, and that trend is likely going to continue, that those lines crossed 2 years ago, and they're going to get wider. If we look at survival with solid tumor, and we look at 5-year survival, which is kind of the landmark in oncology for comparison of outcome, you can see that we're not doing so great in lung cancer. If you look back 50 years ago, we doubled the 5-year survival, but it's 25. And we in lung cancer tend to celebrate these small changes in numbers. But it's nothing like 5-year survival for breast cancer, 91%. And actually that continues for breast cancer to 10 and 20-year survival being incredibly good. And then colorectal, 64%, prostate, 97%. And so when you compare lung cancer to the 3 next most common solid tumors, our survival has really lagged behind. And perhaps that's because the other tumors have had much more investment in scientific discovery with more research money, which has led to development of better treatments, and that lung cancer has often tagged along with that discovery. Certainly that's changing, and there's much more investment now in understanding lung cancer. But one could also argue that breast, colon, and prostate cancers all have a very accepted screening intervention, and we can argue about the accuracy of those screening interventions, but they are embedded in medical practice and actually in the heads of our community, so that 75 to 80% of women who are eligible for breast cancer screening get mammography. And we are a far cry from that with lung cancer. And so these interventions where you get early detection have really helped survival for those other tumors. And if we just look at breast cancer versus lung cancer for a moment, you can see why that makes a difference. So this is 2018, and these numbers have actually gotten even more skewed. But for breast cancer, 2/3 of women or more are diagnosed at stage 1 or 2 because of early detection. And that includes not just mammography, but the fact that we teach women breast exam at very young ages as part of their health education in high school. And really a small minority, 6%, are diagnosed at stage 4, where treatment is going to be more difficult and survival is going to be worse. The opposite is true in lung cancer, that about 3/4 of patients are diagnosed at stage 3 or 4. So at advanced stage, where cure is much less likely, although survival can be improved. And maybe 1/4 are diagnosed at stage 1, and that's typically without screening by serendipity. So somebody comes to the ED and gets their PE protocol CT scan, and a nodule is found incidentally, and that leads to the diagnosis of early stage lung cancer, because those patients by and large are not symptomatic, and there's no way to feel your lung the way you can, feel a breast or do a prostate exam. And so it's very clear, and this is the way the staging system is set up. Staging system is set up based on survival. So if you look at stage 1A1, which is a less than 1 centimeter nodule, to 4B, which is metastatic disease, you can see the survival falls from 92% at 5 years to 0. It's not 0 anymore, because we have ways to help people survive with immunotherapy and all of that. But if you take the whole population of stage 4, the survival is really poor. And so that what we really want to do is bring people from advanced stage to early stage. And if you do that, then lung cancer can look like breast cancer in terms of survival of the population over time. And up until 2013, we really didn't have a method to do screening. There was no screening method approved. And I certainly grew up as a student and trainee and attending as state-of-the-art for lung cancer screening is nothing. Okay. Even chest X-ray had never been shown to be of benefit. And that question of can we use chest X-ray for screening for lung cancer was put to rest by the PLCO screening trial. Huge study, 154,000 people, bigger even than the studies CLAR does, and really enrolled over an 8-year period of time and followed for like 20 years. And PLCO actually was forced to report out its lung cancer screening results, and they used chest X-ray versus no screening, which no screening is state of the art. And you can see this is the data they published in 2011. They actually had to break open their trial to get this. And it doesn't really matter which line this is, because if you look at time versus cumulative deaths from lung cancer, it doesn't make any difference if you got nothing or if you got chest X-ray. So the conclusion is chest X-ray is not effective for lung cancer screening. And that background information was necessary for the lung cancer, the National Lung Screening Trial, which I know you all know about. 53,000 people enrolled to look for a 20% decrease in mortality related to annual screening with low-dose CT. The comparative arm was chest X-ray, and it was predicated on the assumption that the PLCO would show that chest X-ray and no screening were the same, okay? And so the data are here, and what you see is that over time, low-dose CT diagnosed more lung cancers than chest radiography, but the important thing was that there were fewer deaths. So more cancers and fewer deaths. They reached that target of 20% mortality reduction early, and the study was closed. And so what you see is more lung cancers diagnosed. The cumulative risk of lung cancer for 6 years was 2.6%, and I want you to kind of hang on to that number, 2.6% over 6 years. 60% were stage 1, so early detection was achieved. There was a high false positive rate, 96% of the false positive findings, which were present in 17 to 25% of everybody every year. Those were false positives, so that's a problem, right? Because those generate alarm and sometimes intervention. And the bottom line was screening with low-dose CT reduces mortality from lung cancer. And based on this, the United States Preventive Services Task Force, which advises CMS, Medicare, on preventive interventions, that if you get an A or B recommendation, Congress is supposed to vote to cover that. And I hope that stays true. USPSTF announced the last day of December 2013 that screening should be done in people who are 55 to 80 years old with a 30-pack-year smoking history, currently smoking, or quit within the past 15 years. And that is because that was the population really of the National Lung Screening Trial. It took CMS another 1.5 years to approve this, or Congress. And so screening as an entity that got paid for as a preventive intervention for patients with Medicare went live in 2015. And generally, private insurers follow what Medicare does. And so then everybody started paying for it. But pretty immediately after the ink was dry on the USPSTF and people started looking at NLST and critiquing it, as we should, there were lots of observations that this was not good enough. So in the NLST, women and Black men got lung cancer at younger age than white men, and that just corroborated what we already knew. They also got lung cancer at lower smoking exposure. At this time, there were also all these studies coming out from Europe, the Nelson trial, Cosmos and Lucy in Italy, Lucy in Germany, and more, that were demonstrating that the women in those trials, who were unfortunately often included as an afterthought, like in Nelson, which is really annoying, the women actually did better than the men, that there was actually more benefit with screening seen in females than in males. In the NLST, Blacks achieved a greater benefit in reduction of lung cancer-specific mortality, as well as in all-cause mortality. And this was kind of the first signal that the incidental findings that you see, because the chest CT looks at everything from the kidneys to the neck, and we were finding things like severe coronary calcification. So that was another reason, well, you know, is the population too small? And then is the population too old? So Nelson, the mild study, which was in Milan, Italung, these all included younger people, ages 45 to 50, who also were demonstrating benefit. And these were predominantly smoking populations. And so this one-size-fits-all USPSTF approach may not really work well for lung cancer. It's better than nothing. We want to screen. And there was a lot of concern that these observations of differences in women and Black men actually were discriminating against those populations and sort of biased towards screening more white men. And so there were a lot of studies, but there was a big study called the Southern Community Cohort Study that was done out of Vanderbilt. And when they looked at these Southern communities, which had lots of smoking individuals and a probably overrepresentation of Black people compared to the rest of the nation, what they saw was that most of the lung cancers in Black were getting missed because they didn't meet the smoking criteria or they were too young. And so that sort of study fed into the USPSTF revision of the original recommendation, and this was released in 2021 to make the age at eligibility younger, so drop to 50, and the pack year smoking history lower, so from 30 to 20, although they retain the currently smoker quit within the past 15 years. And the anticipated outcomes of that change, nearly 4 years ago, was that it would increase the number of women, Blacks, and whites qualifying for screening, but it would increase the proportion of women and Blacks in that screen eligible population. So we come back here and most of you got this right, that who is eligible, you want to screen everybody, but this person is eligible. 50-year-old white male, 20-pack year smoking history, quit 15 years ago. He's just getting in, right? He's just old enough, just enough smoking, and didn't quit so long ago that he's not eligible. And that's really what screening is based on. None of the other stuff, college grad, BMI, COPD, personal history, blah, 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 even though we know those might be important. And those other 3 people don't qualify. So that if you sent them for screening, there's every chance that it would get denied. Medicare doesn't pre-authorize. And we've all probably experienced that they'll deny the scan after it's done, and then somebody has to pay for the bill, and it's usually your patient. So at least we should screen the eligible population. That's about 14 million Americans whose screening should be paid for. And today I saw 2 people who should have been screened and have cancers now, And I can't tell them you should have been screened, like, a lot of years ago, you might not be in this situation. So how are we doing? This is Connecticut with the little red line. And this is data actually from 2018 prior to the revision and recommendation that expanded the population. So we were doing better. So up until like 2021, we were getting in Connecticut to like 12 and 15%. And the minute the population got doubled, we went back to 6%. We're probably not quite this bad. It's probably like 10 to 15% now, but that means that 85 to 90% of people who are eligible are not getting screened. So we're not doing such a good job at this. Okay, so now what? What do we do? So this is kind of my analogy that you'll have to bear with just for a little while. So we have this planet we've identified that has lung cancer screening eligible people who live on it. They all meet those criteria, 50 to 80, 20-pack years, quit shorter ago than 15 years or still smoking. And then we have this planet of people with lung cancer. Now, unfortunately, that planet is pretty big still. So we want people to screen so that they don't land on that planet, or if they land on the planet, they have early disease so we can cure them. Having said that, even if everybody got screened, those 14 million got screened, we would still identify less than half of all lung cancers in this country. So that screening intervention is going to miss most of the lung cancers, not like 80% of them, but more than 50%. And part of this is that lung cancer screening is different than all other cancer screenings because of this eligibility thing that has stuff in it other than you're old enough. So, colon cancer screening, they keep dropping the age at which you should have colon cancer screening, but they don't ask you anything else, right? 45 now, go get your colonoscopy. And then you keep getting it, right? And so this behavioral requirement that you have to talk to the patient or they have to acknowledge to you the intensity of their smoking is definitely a barrier. And we know that the fact that you quit 16 years ago doesn't mean that your risk goes away. And you're certainly older, so that the risk related to age has gone up. And there is this requirement that you talk to the patient, which is not unreasonable, about the pros and cons of screening. And this has to do partly with the 96% false positive rate for a positive finding. And also, not so much, but in my mind, because this is a full chest exam, and I gotta, I'm gonna prepare you for the fact that you have a 20% chance of having a nodule every time you have a new scan, but I'm not preparing you for the fact that your aorta may be a little big and you may have coronary calcification. I might find a thyroid nodule or interstitial lung disease or the, myriad other things that show up on CT scans. So the important takeaway message is that the current eligibility requires that you have this discussion, but doesn't allow you to include, doesn't allow us to include consideration of factors we've known since we were medical students contribute to lung cancer risk. And those are the things patients are asking us about, right? Okay, same for people, I'm not going to read it again. Which of those people has the lowest risk of lung cancer over the next 6 years? Okay. Ooh. Fair enough. We're not agreeing. Okay. It's the guy who's eligible. Actually, that's not fair because I don't know about this 7-year-old Asian woman, but I'm going to show you some data later that her risk is probably higher than his. Okay, he meets USPSTF, but when we use risk calculation, he's pretty low. And so there are lots and lots of these validated lung cancer risk prediction models out there now. And the two that are available to you are the PLCO modified 2012, and this was developed in the PLCO trial. So this is not NLST. This is those 150,000 people having been followed for, decades. And then the Liverpool Lung Project model. And the city of Liverpool actually, I guess, funded this thing where they started collecting data on like the entire population prospectively, smoking and not smoking. These are publicly available risk calculators. This is the PLCO risk calculator. These models were all developed in prospective preventive studies, vitamin studies, screening studies, whatever. And they collected a lot of data about, individual demographics. So the models can include that other information like your race, your socioeconomic status using a substitute like education, a zip code, medical history relevant to lung cancer like emphysema or exposures to stuff other than cigarettes like asbestos. And in our program, Polly Sather and Krista Casey, who do the hands-on work with the patients, do this PLCO M 2012 evaluation with patients during the decision support discussion. Sometimes it's to encourage them to do the screening, and sometimes it's to dissuade them from their worried, need to screen. If they don't qualify, they shouldn't necessarily have it, and you don't want to do a screening study in somebody whose risk is so low that you're only exposing them to a little bit of radiation. So here's our guy. He's 50 years old. He is a college grad. His BMI was 27. He's white. He doesn't have a personal history of cancer, COPD, or a family history of lung cancer. He's a former smoker. He smoked a pack a day for 20 years and he quit 15 years ago. You plug in those numbers and this PLCO model spits this thing out at you. The probability of lung cancer in 6 years is 0.002194. So his risk of lung cancer is 0.22% over the next 6 years. And remember, NLST was 2.6%. So his risk is tenfold lower than the average person in NLST. And I put here, this is where you can get it. All you have to do is Google lung cancer risk assessment PLCO, and you will get a link for you to sign up. And what they want to know is who you are, where you work, and what you're using it for. I've had to do it a jillion times because I'm never in the right place to get the one I've got. So that they've got me listed like many times. So risk prediction has become much more of an issue since NLST because of this concern that we are missing so many people. And even within NLST, the risk was not the same across the board. And so the study by Kowalczyk and colleagues came out very quickly, 2013, after NLST, which was published very late, 2011. And they made a model using the NLST data that included age, sex, race, BMI, factors of smoking, years since quitting, whether or not you had emphysema seen on the CT, and the family history of lung cancer. And what they did was they took that model and said, okay, we're going to divide the whole NLST population that got low-dose CT screening, that's 26,000 people, and into quintiles of risk. And so here are the quintiles. Quintile 1 was very low risk, 0.15 to 0.55%. That's our patient, our guy, the 50-year-old guy that we've been talking about. And the highest quintile risk was risk of lung cancer, and this was observed right in the NLST, more than 2%. And when you look at then the quintiles, you start seeing very different very different outcomes in the population. So again, NLST, the risk of lung cancer was 2.6, it should be, 6 years. The number needed to screen of the population, 194. So that's 194 people to get a screen to save one lung cancer death. We know what the benefit was. It was mortality reduction. And the harm is really kind of what they were getting after here, that it's really 20% annual rate of positive findings. It was 24% in NLST, of which the vast majority are false positives. And so if you look here at this lung cancer deaths prevented by low-dose CT, what you see is that the benefits all up here in quintile 5, right? But not just that. There was definitely some improvement in both situations, both quintiles in stage 1, although these quintile 5 people, more of them showed up with more advanced disease. There were many more cases in the highest risk quintile than in the lowest, and many more deaths. The number of false positives per prevented lung cancer death was way lower in the high risk group than in the low risk group. And the number needed to screen was better than overall NLST, but look at this. So you had to screen 5,000 people who were that low quintile risk to save one lung cancer death. So we were so happy when NLST came out because it provided the evidence for USPSTF to make that recommendation, finally. But we know this is behind there, and that's kind of problematic. So that when the USPSTF revision was being worked on, and everybody knew about that, there was an open comment period, and everybody sent in, we should be using risk modeling. We should include risk assessment in the decision about screen or not screen. It can't just be age and smoking. And when the recommendation came out, it was age and smoking. And buried in like the e-supplement somewhere was this huge discussion by CISNET, which is the modeling group of which Yale is one of the 6 sites, of why it wasn't included, because there had been this kind of medical outcry to take advantage of the data, right? And really it made sense, although it was very frustrating. If you decide you're going to screen based on risk, how do you decide what the threshold for screen, not screen should be? And the way they went at this was, okay, there are 8 million people based on the original USPSTF eligible for screening. So if you wanted to set that 8 million people number and then not screen any more than that, so it wouldn't cost the country any more than that, you'd be screening higher risk people, right? Much more efficient. You'd find more lung cancers. There'd be fewer false positives, more cost effective, but you would screen fewer people and you would prevent fewer deaths. Okay. If you set the risk lower, which is kind of where we were all going, you'd screen more people. They did that effectively by saying less smoking, younger age, and the screening gets less efficient. So now we're worried about, okay, am I going to have to screen 5,000 people to save one life? You'd prevent more cancer deaths because you're screening more people, but there'd be way more false positives, right? Yeah, this is the 5,000 actually. So it'd be way less cost effective. So reading this like buried in the supplement thing is like, okay, this kind of makes sense, but I think we could push back at the why 8 million? If this is a leading cause of cancer death in this country, why are you limiting screening? You should really still expand it, but the cost would be enormous. Try to get that through Congress now. And this was like, 2020. So anyway, this doesn't help us because we're about this, right? You have the ability to measure risk. And when you see that that risk is higher than the high risk of the NLST, what are you supposed to do with that? And so this is the not so obvious part, right? Because I don't have real answers for this. So that all those people who live on that moon are fine, right? But then there are a lot of people who we know will get lung cancer who don't live on that moon. They're like floating around in outer space without a place to land. So these are the people who are older but healthy enough to benefit from screening and intervention, or the people who quit more than 15 years ago or haven't been smoking, intensively enough to have accumulated 20 pack years. And there are a lot of those people out there. So now let's go back to the other patients. Okay, so here's our 81-year-old woman, 60 pack year smoking history, high school graduate, BMI 27. She's got COPD. She's never had a cancer, but her father died of lung cancer. And when you enter her into that PLCO model, here's her risk, 37.5% over the next 6 years. And let's say she's a young 81. She waltzes into your office like, in her tennis clothes, and she wants to be screened because I want to live till I'm 100, which is actually likely if she's so healthy, right? Even though she has COPD. What do you do with her? Do you tell her no? You don't have to raise your hand. And then what about the patient C, 74-year-old Black male, 30-pack year smoking history, stopped 20 years ago. So he's not eligible because of that. She wasn't eligible because she's too old. He's not eligible because he stopped smoking too long ago, right? College grad, BMI 25, he has COPD, his mother died of lung cancer. His risk is 6.4%. Compared to her, it doesn't sound so bad, but that's 2.5 times NLST, right? And so he's in that, he's like in, if there was such a thing as quintile 6, which of course there's not, he's in the high end of quintile 5, right? That the likelihood that he's going to get a cancer if he doesn't already have one is pretty high. So my moon thing is not working, right? So we'll pick a different planet. So here's Titan. Titan, the Greek gods. It's the biggest moon of Saturn, right? So we'll make that be this one because that's nearly half of all the population. And so that's now, instead of this little moon, we have this like big moon with that's actually a big planet. And we'll just add people. Lung cancer screening eligible based on high risk. And we'll just have to define a threshold somewhere, and we're going to push USPS to do that. That sort of works. But what about all these other risks that we know about that, again, we've known about since we were students? Positive family history of lung cancer. Personal history of cancer ups your risk. Chronic lung disease, COPD, alpha-1 deficiency, interstitial lung disease, mycobacterial infection. Practically every lung disease that causes inflammation probably should be on this list, right? All of you have patients who are at risk. And then all those occupational things that we ask about, workplace carcinogens, radon, and the radiation that we give to patients diagnostically and sometimes therapeutically. The risk of lung cancer if you had radiation for Hodgkin's, particularly in the olden days, but even now, really goes up. Breast cancer radiation increases the risk for lung cancer. Should we be screening those women? There are a lot of women who got breast cancer radiation. Outdoor pollution. And then all this stuff indoors, radon in the United States, passive smoking, and then in the rest of the world, indoor pollution and burning of biomass fuels. Okay, so now you're in a clinic, you have a patient who's concerned that they're at increased risk for lung cancer, wants to be screened, and you agree. Okay, you've got that ILD patient whose mother died of lung cancer, and you're looking at all that fibrosis on their scan thinking, yeah, they're at risk, maybe I should screen them. So what do? Because they don't meet eligibility. And if they're Medicare age, you have no way of knowing if that scan is going to go through and be paid or not. And it'll get done, but might not be paid for. So A, inform the patient they don't qualify for screening and don't order it. B, order a chest x-ray. C, order a low-dose screening CT and see if it makes it through pre-op. Or D, advise the patient to pay out of pocket and send them to the lowest cost site in your area.
Lynn, could I just raise an additional option on there, or do you want to wait till the end?
Yeah, go ahead.
Well, this comes up all the time, certainly in our COPD clinic. And there is another, dare I say, workaround for this, which is actually to order a regular CT scan, but request it be done with low-dose radiation technique.
You can do that.
And that gets several things accomplished. It screens for the cancers, also identifies the characteristics of the underlying COPD and so on. So I wonder if you'll, when we get to our question and answer session, sort of comment on that.
You know, there are 1,000 workarounds, right? But that's a good one. Is this being recorded? Yes. So I'm not telling you not to do that, but recognize you're screening with a full dose radiation CT. Actually not, because you ordered it low dose. Okay, you ordered it low dose. The patient will get the scan. If you had sent the patient for screening somewhere to a program, to the VA program, Hillary's here, or to us, they're going to get tracked, right? And so the falling through the cracks thing is part of the benefit of screening appropriately. But yeah, you know, you could do that. And then are you going to do that every year? You know, yeah. So I bless you. You know, you figure out a way to get the patient the care. So this reflects you're trying to get the patient the care they need because you perceive there is this risk and you want to screen them, but there's no way to do it right now, right? Private insurers often let it go. Medicare, sometimes not. And it's totally impossible to predict. So, you know, I think ordering a chest x-ray is totally legitimate, particularly if the patient actually wants a screen because they have a symptom. Actually, if they have a symptom, you can order the CT the way Carly suggested, but with a diagnosis, you know, it's going to get that through. And so that's kind of this one, right? Order a regular low dose CT with a symptom or diagnosis, you know, it's going to get paid for. That's kind of what your approach can be. We're being recorded. I won't say you have done. And we do this. I know where the lowest cost place is in Connecticut. It's actually at Norwalk Hospital right now. And we will tell people, go there and get it done if you really want it, because you can walk into Norwalk Hospital and say, I want a lung cancer screening study, and they will do it. They don't need an order.
What does it cost?
I think $140. And it's way more than that here. Okay, so this was just to take the temperature of the room, but I think we're all doing kind of variations on this. If you have worried well, though, don't screen your worried well. Don't expose them to radiation and the likelihood that they will have something on the scan that is nothing, but is only going to add to their worry, right? The hardest thing in medicine is not to do something, right? Or to talk the patient out of not doing something. And I tell people this, I'm telling you not to do this. And that's a really much harder thing for me to do than to tell you just go get it done. And often that helps in that discussion. There's this great website that was built at the University of Michigan and is now available nationally. And this I find useful, both ends of the reassure the worried well that they don't need screening and try to help people who will make the effort to go to this online program understand why the risk is high enough in their case to be screened. And then you keep running into people like don't fall in the right categories. So this is a patient of mine. He's not eligible for screening. 74 years old, lovely guy. During high school, he worked for 2 summers doing insulation, where they were like making snowballs of asbestos and throwing them at each other. You know, you have patients like that. He smoked cigarettes for 10 years when he was young. And for years and years, he's known he has bilateral pleural plaques. He doesn't have asbestosis, he doesn't have ILD, but you can see he's just lined with these plaques, some of which are calcified. He knows, he's well educated, that pleural plaques reflect his asbestos exposure, which he can describe, you know, and he knows asbestos exposure is a risk factor for lung cancer. And there are many, many, many more lung cancers in this population than mesothelioma. Okay. And he knows he doesn't meet USPSTF criteria. So what do you do with that, right? Asbestos is a known carcinogen. It's the single most important cause of occupational lung cancer mortality in the world, 184,000 deaths a year. It's restricted and regulated, but not banned in the US. There's no way that we could get rid of all the asbestos that's in our buildings, and it's in the rocks in some of the communities, right? OSHA has a ruling that the employer is required to do medical surveillance if they know that the workers are exposed to asbestos above the permissible limit. And that includes medical and work history, respiratory questionnaire, physical exams, spirometry, chest x-ray. So they're not screening either. They're looking for asbestosis, right? They're looking for interstitial lung disease. But there are plenty of papers out there that suggest that plaques are a signal, that if you take patients with pleural plaques in these studies. This was a pooled, wasn't really a meta-analysis. They just pulled the data from 9 studies. What they saw was that if you looked at those patients and screened them, there were more patients who had this asbestos exposure who had pleural plaques and had lung cancer than if the pleural plaques were not present. And it's probably a signal of the intensity of the asbestos exposure. And interestingly, that Liverpool Lung Project risk assessment model includes asbestos exposure, presumably because there must be a lot of asbestos in that area, or they've got a quarry, or there are lots of industry working with that. And so their model, when they ran it with that history of asbestos embedded in the questions, asbestos came out as an independent predictor. So the UK just implemented lung cancer screening like 2 or 3 years ago, and they're doing it with the Liverpool lung cancer assessment. And so they have chosen in the UK to go with risk, not with demographics, all right? And basically they set this level at, if your Liverpool Lung Project risk assessment predicts a more than 2.5% risk of lung cancer over 5 years, you get screened. And I don't know where 2.5% came from, but it's so close to 2.6% that I'm sure that informed that, where do you set the bar for high risk? And so here's the LLP, all right? And I think what they did was they sent this questionnaire to everybody in the country, right? It's simple. What's your age? What sex are you? Have you ever had lung disease, right? Everybody's had pneumonia, emphysema, bronchitis, TB or CP. This is really inclusive, right? Have you had a cancer? Were you exposed to asbestos? Is in there because it was predictive in their presumably logistic regression model. Do you have family history? How young were they when they were diagnosed? And did you smoke? They don't ask you how intensively you smoked. Getting people to figure out pack years is impossible. Getting doctors to figure out pack years is like, oh God, I quit when I was this and I started again. I haven't been smoking this. I'm going to make a rough estimate. It's going to be in your chart and you're not going to like it. Don't email me back that it's not 20 years. Okay. I've had that happen once. And then you press this button. This is like it's being sent out to people. Press the button, it's online, and you get this, your risk of developing lung cancer over the next 5 years is, and his is 2.53%. So if he moved to England and had national health insurance, he would actually get screened. He's not going to move to England. But it just kind of shows where we're at. This is a very not science thing. Okay, so then we'll come back to patient D, that 70-year-old Asian woman, never smoker, completed some college, BMI 25. She has chronic bronchitis. She had breast cancer 10 years ago and father died of lung cancer. What do we do with her? And this whole thing about lung cancer never smokers is going to be a much bigger topic as the years go by. So those of you who are particularly in the early years of your training or planning on being a pulmonary attending for at least the next few decades are going to have to grapple with this, okay? If you just take the lung cancer never smokers, it's the 7th most common cause of cancer-related death in the world. And in the United States, lung cancer in never smoking women is the 7th most common cause of cancer death in women in the US. It's not a small problem, like more than uterine cancer, right? And we are seeing more of this, right? It used to be really rare, but we are absolutely seeing this. It's not like a surprise anymore that you see people with lung cancer, now more men with lung cancer who never smoked. And the reason is the population is changing. And so there's this really great article published a couple of years ago that simulated this. And when you see it in a visual, it totally makes sense. So here we were like around 1960 or 65, first Surgeon General report, right? At that point, 75% of men in the US are habitual smokers. Amazing. And over time, that big green group, who are the current smokers, is falling off. Although again, 14% of the adult population in the US are habitual smokers, and an increasing number of youth are smoking something, vaping, cigarettes, marijuana. That big group of current smokers, a lot of them quit after 1965. The public health interventions about stop smoking actually really worked. So understanding the health consequences of smoking, and that was the title of that report, led a lot of the population to stop smoking. And that's resulted, right, in a decline in lung cancer. So this lighter green, so the middle green are the ex-smokers. And you can see that population is going to grow for a while. It's been actually, we're kind of here. So it'll eventually diminish, but it's going to stay substantial. But what's really growing is this never smoked population, because the population of the US is increasing. We are still a growing country with a lot of young people, as opposed to like Japan, where everybody's getting older and there are very few young people. And so just by numbers, sheer absolute numbers, the number of lung cancer deaths in people who never smoked is going to go up. So we're here about, 20, and you can see that's already happening, right? So the number of cancer deaths in people who are currently smoking is falling, because the number of people who currently smoke is falling. It's going to take a lot longer because there are a lot of ex-smokers. And as they age, they will have more lung cancers. Because again, the risk of your last cigarette, the further away it is, your risk falls, but you're getting older, right? And all the exposures you've had over your life and your age are risks. And then this light green bar is following this big balloon in the population. And so eventually, we're projecting out to 2070, but this is mathematical, right? I don't know actually what's really going to happen, but something like this, there will be many more lung cancers in never smokers. So that maybe we're headed towards a good place, and buried in this never smoking population are a lot of people who have genetic mutations that are driving their cancers. They don't have multi-mutated cancers from smoking. It's a different kind of lung malignancy. And so we're ahead of the curve maybe, because the minority of patients now are eligible to be treated with targeted agents, but it may be that population will grow. They do better, but we never cure their cancers with that kind of therapy. So we are totally not there. So I made this woman Asian, because I am. And it was like, okay, I'm interested in this population, the never smoking Asian women. Okay. And really, when you look at it in Asia, and in parts of the world where women don't smoke much, the majority of lung cancers in the female population occurs in never smokers. And it's been attributed predominantly to indoor air pollution. They're cooking in non-ventilated places, they're using biomass fuels, and they're constantly exposed because they live in rural areas and don't have the advantage of developed countries. And so there's this very interesting study going on now, the talent study in Taiwan, and it's for never smokers. So this is like kind of unique. There's another one going on in China. And so to get into this study, you had to have a family history of lung cancer. You had to one of these, okay? Or passive smoking exposure, or a history of lung disease, TB or COPD, or exposure to cooking fumes. And this is a prospective study that's now been going on for a number of years. It took them forever to announce their initial results. 12,000 people were enrolled, of which 3/4 were women. Lots of men in Asia smoke, so they wouldn't have gotten into this study. Ages 55 to 75. You could smoke less than pack years, but it had to be distant. So these people were ever smokers, but they would not be screened based on like what we use in the US. And then they had a low-dose CT at baseline, then annually then 1 year, and then every other year for a total of 8 years. This kind of mimicked more the Nelson trial in Europe, less radiation over a given period of time. So they published these results a little over a year ago. 2,000 of the 12,000 had positive results on baseline CT, 17%. That's just like NLST, a lot of findings on this kind of scan. There were 318 lung cancers, and this is on the prevalent scan, the first scan. 257 of them were invasive, meaning they got resected, they looked at the histology, and they were not one of these precursor adenocarcinoma things, which is like adenocarcinoma in situ. These were actual cancers. 246 of the combined 318 were stage 1. So they accomplished the early detection piece. And what was the strongest predictor was positive family history, particularly if you had more than one primary relative with lung cancer. Okay, so now we've made many moons for Saturn, right? And we'll make another one for the female Asian never smoker who has a family history of lung cancer. That's me, actually. And this is not going to work, right? Saturn actually now has 145 moons because they keep discovering new moons. And that's what would happen if this model I created kept going. And so by the time that somebody else gives this talk in 5 or 10 years, we will be in the future state of we're not just going to rely on low-dose CT. So Ed Ostrin at UT Southwestern made this really nice analogy that this is the iceberg of people who could be screened, right? The tip of the iceberg, which you can see, are the people who you know are eligible based on current NLST. But the big part of that iceberg you can't see. We cannot screen right now. And so there are people who were ever smokers and people who were never smokers. We'll divide it up that way. And so we could say, okay, these people need to get a low dose CT. And when we find their nodule in 20% of the cases, we will do biomarker testing using all the samples we can get reasonably non-invasively. If we could just figure out the prediction of which of these blood, protein, epithelial cell, DNA and RNA changes predict the risk of lung cancer high enough that you'd biopsy the nodule that you found, right? And for this big bulk of patients, you would use that biomarker testing to identify the people who should then get a low-dose CT so that we wouldn't screen the entire population and bankrupt the nation and expose a lot of people unnecessarily to radiation. But there's a path forward to get back to, we can identify the people who should live on that moon, who should be screened based on a comprehensive evaluation of their individual risk, based on biomarker evaluation with imaging, and that we turn this planet into a planet of lung cancer survivors because we're going to find people early. So screen, please. You have tools. You can do the risk assessment with very easily available tools online. If your patient is high risk or worried well and doesn't meet criteria, use the tools you've got to help them through that. If you really want to screen somebody, there are ways to do it that you will figure out, that I do. And then, always, if they're still smoking, do the counseling at that time. It is a teachable moment. The people in the NLST, even when they had good results of their studies of the LDCT, they quit. And that's it. Thank you. Well, I think we're probably out of time, but a couple minutes.
2 minutes. Yeah, anyone have any questions? Yeah.
And that was excellent. The question I have has to do with how does better treatment factor? So I was thinking that if we repeated the lung cancer screening trial, which is over 10 years old now we would probably see a more robust mortality benefit, I would think, because our treatments and therapies have gotten better, biologics, et cetera, and so forth. I'm just curious how that changes the risk-benefit calculus for screening.
Yeah.
And is that factored in at all in USPTF or other screening recommendations?
So that really the most of the weight of the benefit is because you can do surgery, right? And so those patients do not need any other therapy than resection, and then they get monitored. So that early detection is still the key. Even though immunotherapy, targeted therapy, better chemotherapy, all of these things are helping people with more advanced disease, there is significant cost, of course, but personal cost, that these therapies are not safe. Ask Jennifer, who she sees in clinic, and it's people who are getting these new therapies with rip-roaring lung disease or something that is actually ruining their quality of life. And so the best therapy would not have to give it. And so it is true that all of those therapies are moving backwards in the staging, so they're being given at earlier and earlier stage because they improve survival. But the most important improvement of survival is to diagnose something early, and we've seen that in breast cancer.
I think we're gonna have time for one more question here.
Hi, thank you for the great talk. So an eligible patient, I sent him to a CT, and the CT is perfectly normal, but he continues to smoke and he doesn't have any other risk factors. So how often should I rescreen him? Thank you.
So screening should be annual. In the US, it should be annual. In Europe, and in the Nelson study in particular, which was the other big study that showed mortality benefit, they did what the Talent study is doing, scan it 1 year and then 2 years and 2 years and 2 years to minimize the radiation. Radiation is cumulative over a lifetime. And so that's one of the reasons that you see more lung cancer as people get older, because we are exposed to ambient radiation, from the sun. So when I look at some of our patients and the amount of diagnostic radiation they've had, and there really isn't a good way to add it up. I know some places are trying to do that, but what you're concerned about for lung cancer is radiation to the chest. And that is your scatter from every scan they get. What you're concerned about with renal carcinoma is radiation to the kidney. And so it sort of depends what organ you're worried about. But the cumulative dose of radiation, if you got started screening at age 55 and kept going, something like there would be 1 lung cancer from the radiation of the screening in 10,000 screens. So this keeps coming up because arguments against screening, but it's sort of, when you look at the number of life saves, it's like this, yeah.
All right, one last question.
One last question.
Okay.
No, thank you, Lynn. That was great. And I think you've given us hope that we're going to be able to do it better as we refine our tools, as we move ahead into biomarkers and all that. And I think doing screening well is key. And I guess the piece of that we should all acknowledge is that selection is one thing, but adherence is
Yeah,
everything.
right. Retention
And
is a problem.
all of
Yeah,
these studies
right.
have had terrific adherence. And that's really key to success,
Right,
right? I mean, we can't do it just by enrolling. We have to
Right.
keep them at it.
Right. And so to your point, patient has to have a scan every year to get the results that the NLST showed, right? Are they really going to come back for a scan every year? Many people do, but tracking patients down to come back for their screening when they feel fine, because you only screen well people, right? Is a problem. And across the country, I would say the retention rate in screening programs is probably around 20%, because colon cancer screening you get every 10 years, right? Breast mammography in a sort of a not high-risk population, maybe every 2 years. And then prostate, I have had patients tell me that, oh, their doctor said it wasn't a good test, so they're not doing it anymore. Okay, and so retaining people when they feel well in this kind of program is a challenge. And I'm sure, Hillary, you've seen that at the VA, yeah.
Boots on the ground is really
Yeah.
the key to success. And, the VA is, as you know, that 70% adherence
Yeah,
for
right.
broadly, and, even higher than that for the first
Right.
couple years.
And
of
so
adherence.
closed population, you have like
Yeah,
the
that's-
VA, Kaiser,
it's the medical home.
yeah. But that is unfortunately not how healthcare is set up for most Americans. And so we struggle with this. All right, thanks so much.